Good morning and good afternoon. We're going to wait just a couple minutes as people continue to join, and then we'll get rolling in about a minute. All right, I think people will continue to join, but we'll go ahead and get started because we have two really engaging speakers and topics today. So on behalf of my co-chair, Ken Mayer, welcome to the Antiretrovirals for Prevention seminars today. And the format today is we'll have two talks. We'll ask you to save questions for a question and answer period at the end, which Dr. Mayer will moderate. So I'm going to introduce both of our speakers, then we'll have two talks and questions after. I'll also remind the participants and our speakers that the session is being recorded, and we make these available through our listservs. And so the folks who are here today get the first view of these great talks, but they'll also be seen by many colleagues in the coming weeks as the links go out. So it's my pleasure to introduce two great speakers. Dr. William Godel is an assistant professor in the Department of Epidemiology at Brown University School of Public Health. And his research uses a variety of approaches ranging from traditional observational cohort studies to computational models to understand how to improve the population level impacts of existing and emerging biomedical HIV prevention methods. The overall goal of this research is to inform efforts to end the epidemic among gay men in the United States. Dr. Godel holds a PhD in epidemiology from the Brown University School of Public Health. After his talk, Dr. Bohdan Nosek is an associate professor and St. Paul's Hospital Kanfar Chair in HIV/AIDS research at the Faculty of Health Sciences at Simon Fraser University and leads the Health Economic Research Unit at the Center for Health Evaluation and Outcome Sciences. Dr. Nosek's research seeks to inform complex policy decisions surrounding the prevention and management of HIV/AIDS and substance use disorders. He combines simulation modeling methods and cost-effective analyses with econometric and biostatistical analyses of health administrative data to address these issues. So from those introductions, I hope and expect you're as excited as I am for their talks today. And Dr. Godel will kick us off.
Sure thing. Thank you for the introduction, Patrick. It's really great to be here. Thank you to Patrick and Ken for the introduction. Today, I am going to talk for about 20 minutes about some of my work that's related to projecting the impact of what equity-based provision of PrEP could look like for men who have sex with men. And I'm going to talk about a class of mathematical models known as agent-based models and introduce you all a little bit to this method. To start, I have no conflicts of interest to disclose, but this work was supported by grants from the NIH. Just to give us a very brief overview on kind of what our current state of HIV prevention is in the US, most of you are familiar with this. Building off of work from the CDC that looked at changes in estimated HIV incidence over the last decade, we know that HIV incidence among men who have sex with men has been sort of stubbornly high. And has seen very few decreases nationwide over the last decade. And when we look more specifically within subgroups of men who have sex with men defined by race and ethnicity, we see that there's quite a bit of heterogeneity here. These charts, you're looking at an estimated annual % change in HIV incidence over the last decade. For different groups of MSM defined by race and ethnicity. And you can see here more clearly that the only group we've really seen consistent, measurable declines in HIV incidence is among white MSM. Black MSM, who have among the highest HIV incidence in the United States, have really seen no change over the last decade. And even we've seen some small increases in HIV incidence among Latino MSM. And so this is really the context of my work, is that we have some groups that are benefiting tremendously from our existing HIV prevention strategies and others that we have a lot more work to do to reach them and to develop prevention strategies that work best for them. We have a fantastically broad HIV prevention toolbox available to us that is expanding every day. Many of our options listed here. Given the focus of this working group on antiretrovirals, I'm going to speak mostly on pre-exposure prophylaxis as one key part of our HIV prevention toolbox. To give a brief definition, PrEP, as we all know, is the use of antiretroviral medications by individuals who are not living with HIV infection to reduce their risk of HIV infection. Since 2012, we've had 2 pill-based regimens approved by the FDA for use as PrEP that both are tenofovir-based. Most often for everyone, they're recommended as daily pills. For men who have sex with men, they can also be taken on an event-driven basis in a 2-1-1 formulation, depending on an individual patient's needs and preferences. And this year, we've now seen the introduction of a bi-monthly injectable formulation involving cabotegravir. So it's an ever-expanding toolbox where we're able to use antiretroviral medications for preventative purposes. And these have really seen sort of widespread success in terms of uptake among some groups of MSM in some settings. Some MSM and some settings sort of being the key phrases in that setting, in that sentence. Based on estimates from the CDC, we know that there are many, many people that could benefit from medications like PrEP. The CDC has estimated that there's about 1 million people, I believe, that are indicated for PrEP based on underlying risk behaviors, most of whom you'll see are Black men who have sex with men in this graph here. So hopefully if PrEP was getting into the hands of people who needed it most, we would see that most people on PrEP were Black men who have sex with men. Unfortunately, we know that there are significant racial and ethnic disparities in who is able to use PrEP. These were estimates from 2018 of the number of individuals prescribed PrEP by race and ethnicity, recognizing that a significant amount of racial ethnic information is missing in our large prescription databases. So we might be underestimating the number of people prescribed PrEP of certain racial ethnic groups, but we can see that by far the majority of people who are prescribed PrEP are white, despite the fact that the majority of people who are indicated for PrEP are not. To give you some slightly more detailed data for MSM, this comes from the National HIV Behavioral Surveillance System conducted by the CDC, where they were interested in comparing changes over time in awareness of PrEP and use of PrEP in their NHBS sample. So this is largely restricted to men who have sex with men who are at risk for HIV infection who live in large urban settings, as that's the target sampling frame for NHBS. And we can see that awareness of PrEP has increased over time in all groups. Particularly early on in 2014, Black and Latino MSM were significantly less likely to be aware of PrEP, but those gaps have closed over time. And if we look at the percentage of MSM that have used PrEP in the last year, we can see that although we've seen some really dramatic increases in the use of PrEP among MSM in all groups, we can still see there's gaps in who's able to use PrEP. And really, what my work is interested in is understanding what the potential implications of these inequities in PrEP use are for our long-term trajectories for the HIV epidemic in the US, and ultimately understanding what we can do by intervening on these disparities. This part of my research portfolio uses mathematical models, and I think they're particularly helpful for a couple of reasons that I will articulate here. Mathematical models really help us to make and test specific hypotheses about the mechanisms underlying infectious disease transmission. Because they're artificial, they're simulations, we have as researchers complete control over every sort of element that's represented in a system in a mathematical modeling. So we can hold all sorts of things constant and change one circumstance or change one value of one parameter and really estimate what the impact of changing that one thing is, whereas the real world's a lot more complicated than that. We can't hold the HIV treatment cascade constant for the next 10 years and see what PrEP does alongside of that to get a sort of clean comparison of what different levels of PrEP uptake would do. But a mathematical model allows us to do that and allows us to do that a lot quicker than waiting to observe those sorts of things over 10 years. And particularly mathematical models also help us more easily understand the results of interactions between individual parts of a system in a way that we can't easily glean from observational studies. And what I mean by that is that an individual's decision to go on PrEP is an individual decision shaped by factors at the individual level, at the interpersonal level, and at the community level. But the effect that that person going on PrEP has impacts on outcomes beyond just what that person experiences. It has impacts for the networks of people that they're embedded on. That has secondary effects on even further degree contacts out from those folks. So mathematical models really help us understand if we can get one more person on PrEP, what's the sort of chain of events that we're preventing if we can prevent that one person from becoming infected with HIV. My work uses a class of models called agent-based models that simulate a complex system with individual entities that can all interact with each other. So think of this as sort of like a public health Sims version of the video game where you have individual people that have their characteristics, their likes and dislikes, and they're all sort of their propensities for behaving in particular ways and the way that they interact with one another. And we're really interested in understanding how those micro level interactions sort of reverberate up into the population level indicators and phenomena that we're most interested in, like HIV prevalence and HIV incidence. So I find that agent-based models are particularly helpful for representing HIV and STI transmission because there is such an inherently network-driven component to it. You know, the risk of HIV infection is not the same for every individual because they have different contact patterns. The characteristics of the individuals that they're interacting with are different. And an agent-based model really allows us to account for and sort of celebrate all of that heterogeneity and what it contributes to what we see at the population level. The agent-based model that my team has developed is called TITAN, which stands for the Treatment of Infectious Transmission in Agent-Based Networks. These two visualizations here just sort of give you a sense of what sort of goes on under the hood. Each of the circles in each of these graphs is an individual agent. There's the size of the circle represents the number of connections that that agent has to other agents in the network. So you can see we have some that just have their single partner off to the side. Others have multiple partners that result in the creation of these large connected components where HIV transmission is possible through all of these different connections. You can see in red, these are the agents that at the start of a model, for example, may be living with HIV. And depending on their engagement with HIV treatment or the use of different HIV prevention strategies by one or both partners, HIV transmission is more or less likely in different partnerships as the model progresses. And these ties can form, they can break, people change partners, people change their engagement with different prevention strategies. And we can look and sort of simulate different versions of the world under different circumstances. You know, one agent's generated at the start of our model, they're assigned partners, they interact with those partners, and HIV transmission is possible sort of at any stage. To give you kind of a look under the hood of kind of what order this happens, we try to generate a population that has characteristics with respect to age, sex, race, ethnicity, gender, and other characteristics as a base population to sort of represent a particular setting. Usually my team likes to do these models to be grounded in particular local settings so that the findings are most useful for people on the ground there. We create a sexual and injection network where agents can then interact. We identify transmission events. We can simulate testing and treatment, and agents can leave the population either through aging out or dying. So it is sort of like a virtual city. And this is repeated multiple times to sort of generate a projection for a particular period. So back to our main question here, kind of what's our potential implication of any racial ethnic disparities in PrEP use for epidemic trajectories? We were really interested in sort of understanding what equity-based PrEP provision could look like. And when I say equity-based PrEP provision, I'll be particularly specific here that I was particularly interested in understanding, one, what our goals for PrEP uptake should be. You know, in the original national HIV/AIDS strategy under the Obama administration, we had a goal, a sort of preliminary goal of increasing PrEP use among people for whom it was indicated, but it was a sort of exploratory indicator. There was no clear goal of what that should look like. We just knew more PrEP was going to be better, but how much is good enough? And that many in the literature were starting to point out, okay, maybe we need to be rethinking about what PrEP coverage should look like. The denominator of who's indicated for PrEP changes a lot over time because people's behaviors change. So it gets really hard to sort of estimate what PrEP coverage is, especially among MSM, where we don't have clear population size estimates everywhere. So I was interested in understanding kind of what happens if we use a more actionable metric, which I'll define in a couple of slides as the PrEP to need ratio, or the number of people on PrEPs, the number of new HIV infections in a setting. And so we created our model to represent HIV transmission dynamics among Black and white MSM in the greater Atlanta metro area. Patrick, you'll appreciate this. Our model is mostly parameterized with data from your ongoing cohort studies. And just as a slide that I like to show off to hopefully, curb off any ideas that all models are wrong, some are useful, that our model is able to recreate HIV incidence estimates from an ongoing cohort of Black and white MSM in Atlanta. So the bars on your left are the observed HIV incidence estimates from this ongoing cohort in Atlanta. The bars on your right show what our model was able to reproduce. And you can see that we're generally able to relatively accurately recreate estimates of HIV incidence among MSM in our model sort of prior to the introduction of PrEP. So hopefully that's enough to start saying, okay, maybe I buy what this model is going to tell us. We were conceptualizing PrEP coverage as the number of people trying to conceptualize PrEP coverage in a way that's actionable and measurable. We can relatively easily measure the numerator in our typical estimates of PrEP coverage that are percentage-based, that the number of people using PrEP is relatively easy for us to estimate if we know how many prescriptions are being written and filled. But the number of people indicated for PrEP in a particular jurisdiction is a little hard to measure because we don't always know how many MSM there are. We don't know how many people who inject drugs there are in a particular area. These things are a little hard to come by. And it's also taking into account that equal coverage is not necessarily equitable. Different communities have different burdens of HIV, so it doesn't make sense that we should be aiming for the same goal for PrEP coverage for all of them. In Atlanta, for example, having the most recent estimates of PrEP coverage from the NHBS were that there's about 0.8 PrEP users for every one new HIV infection in the Atlanta metro area compared to white MSM where there's 2. Obviously, that's telling us that white MSM, despite having slightly lower need for PrEP in this area, are having a way easier time getting on and staying on PrEP compared to Black MSM, and that's a bit of a problem. And so really, I was interested in understanding what our goals should be based on these PrEP to need ratios. We can more actionably measure through our public health surveillance the number of people on PrEP and the number of new HIV diagnoses. So that's like a metric for coverage we can actually pay attention to. And so just to orient you to these, you're going to see a couple of these heat maps on the next couple slides. We're looking at the change in HIV incidence, or whichever measure I might be showing you, relative to a scenario where PrEP is never implemented. So we look over the next 10 years and say, if PrEP was never introduced, what are we estimating HIV incidence to be? And then we can introduce PrEP and look at how HIV incidence changes. And so that's the change in HIV incidence that's attributable to a particular level of PrEP. And we simulated 100 different scenarios here where we're looking at PrEP to need ratios among Black and white MSM ranging from 1 to 10, just as illustrative examples. And to give you a sense of what that corresponds to percentage-wise, a PrEP to need ratio of 1 person on PrEP for every 1 new HIV infection corresponds to about 2% of white MSM in Atlanta on PrEP and being on PrEP, and 7% of Black MSM. We're keeping in mind that our goal now in the Ending the Epidemic initiative is to get to about 50%. So that would be towards the higher end, 8 to 9 people on PrEP for every new HIV infection in Atlanta, and it would be off this chart for white MSM. And so you can see here that the change in HIV incidence as PrEP coverage goes up among white MSM from 1 to 10, we get larger reductions in HIV incidence. And particularly as PrEP goes up among Black MSM, those increases get even larger. Our largest increases were observed when we get to PrEP to need ratio of 10 in both populations. Notice that there's that covariation. You see like it gets darker as you go up as well as over. It's not so much the case for Black MSM. You know, as PrEP coverage goes up for white MSM, HIV incidence among Black MSM doesn't really change. It only really changes as PrEP coverage goes up for Black MSM. This is one thing to just point out, that given the highly segregated nature of sexual networks among MSM and the large disparities in existing HIV prevalence among MSM by race, that the sort of spillover effects of PrEP from preventing HIV infections among Black MSM spill over into white populations, but that doesn't happen in the reverse direction. So really centering on improving PrEP among Black MSM is really the only way that you're going to improve, you're going to reduce HIV incidence among Black MSM. Really looking at our measures of disparity, sort of how does our difference and our ratios of incidence rates change over time? We can see that when the PrEP to need ratio among white MSM is much higher than it is among Black MSM, our incidence rate ratio goes up. So that's our measure of disparity on a multiplicative measure. That's where we would say that the incidence of HIV among Black MSM is 3 times higher than that among white MSM. That multiplicative measure gets bigger if PrEP coverage far outpaces PrEP among white MSM far outpaces PrEP coverage among Black MSM. And what that really tells us is that as you scale up PrEP coverage among white MSM, their incidence drops much faster, so long as it is far outpacing PrEP among Black MSM. So it really sort of behooves us to make sure PrEP is increasing equitably in all groups, so that our disparities are not getting any larger if we're paying attention to them on the multiplicative scale. The incidence rate difference sort of tells us the sort of how many excess HIV infections there are among Black MSM compared to white MSM. And this is really the measure of public health significance, right? We want the gap to be, the absolute gap on the additive scale to be as small as possible for there to be no disparities and for everybody's HIV incidence to come down as close to 0 as possible. And that so long as HIV incidence keeps pace, as long as the PrEP to need ratio among Black MSM keeps pace with the PrEP to need ratio among white MSM, our disparities do decrease. So that tells us we need at least equivalent PrEP to need ratios among both groups, but at least for our disparities to fall faster, we need a much higher PrEP to need ratio among Black MSM relative to white MSM. And so to sort of conclude, without intervention, we know that our persistent inequities in PrEP initiation faced by Black MSM have the potential to exacerbate our existing disparities. Maintaining our status quo is not going to be good enough, and that significant increases in PrEP coverage are needed among Black MSM in particular to decrease HIV incidence and eliminate disparities. It's sort of a no duh, but at least the PrEP to need ratio gives us a sort of actionable way of understanding where we're at with PrEP coverage in a way that can be readily estimated by local health departments. To close, I want to acknowledge my collaborators, particularly Brandon Marshall. This work was conducted as part of my dissertation that I defended maybe about almost 2 years ago now. And that was conducted graciously with Brandon's support. Again, funding from NIDA and from NIMH made it possible. And if you're interested in learning more about our Titan model and want to use it in our research, it's available on our team's GitHub. That was a bit of a whirlwind on how to measure PrEP coverage and what our goals should be. I think Dr. Nosik's talk will really talk about how do we actually get there and how do we use mathematical models to help get to those levels. So I'm looking forward to his talk as well, but thank you all for having me.
Thanks, William. Bohdan, over to you.
All right, I'll just bring my screen up here. I'll start at the beginning. Thank you for having me, everybody. Great presentation, Will. That sets me up very well. I wanted you to go first because I knew you'd have a really good intro section, so I can forgo mine and get right into it. So thank you for that. I'm going to be presenting today on a project that's been ongoing for the last 5 years. We're really grateful to NIDA for continuing our funding for the next 5 years. We're going to keep developing this. PrEP is one of a number of interventions that we're assessing in these 6 cities that we've been focusing on. But it's played a headlining role, and maybe some of the most interesting findings have been around access to PrEP. And again, Will's presentation has teed this up very well. So I'm going to start with my acknowledgement. I always do this. This is an act of reconciliation. And I think it's pertinent in this setting when we're talking about large inequities in access to healthcare. It's something that I keep in mind all the time. So I'm presenting to you from the unceded territory, the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations here in beautiful Vancouver, British Columbia. Our objective in this project was to consider 16 different evidence-based interventions to diagnose, treat, and prevent HIV infection, to identify the highest valued combination implementation strategies to reduce the public health burden of HIV. So this was conceived before EHE came on. Nevertheless, it was aligned in its local orientation. The 90% incidence reduction goals, we adjusted on the fly. Our results were coming out in 2019, 2020, just as EHE was announced. And so we were quickly able to pivot and respond specifically to the feasibility of those goals and how closely we can get. Nevertheless, we judge value on the basis of quality adjusted life years. It's something we use in health economic evaluation. It's a metric that captures the benefits of reduced morbidity, mortality, and transmission altogether. It implicitly captures the equity considerations that we have, and it, by focusing on incidence alone, we're effectively ignoring the benefits that people living with HIV can already receive from antiretroviral treatment. So even though the prevention benefits dominate the discussion in this domain, we still need to consider the benefits that people living with HIV receive from treatment. So our research is now, again, we're 5 years through. We published 25 papers off of this project. The basis of this was developed over the course of 7 papers where we set out our scientific case. We published an evidence synthesis where we described our process of how we pulled all the data together for this. We wrote a couple of papers with HIV-RN data, which were directly inputted into the evidence synthesis. So numbers 3 and 4 were both done with consultation from Kelly Guibo and the HIV-RN group. And we tried to describe very carefully and in great detail how we put this together, because it was a lot of work. Our results are in papers 8 and 9, and I'll be talking specifically to those. Usually I do this talk over 45 minutes and I'm trying to squeeze it in. And so this is a condensed version. I'm hoping if you have questions on the methodology and the background, you can look back to these papers. We focused on 6 US cities. This is really a proof of concept. We believe in cost effectiveness analysis simulation modeling as a tool that can and should be used for decision making across the board. This is our first attempt at trying to do this at a large scale. I think we need models like this across disease areas, calibrated locally. It's hard to do it. It takes a lot of time. And so again, this is a proof of concept in that over the next 5 years, we're going to be expanding this effort to try to do every EHE jurisdiction. These 6 were chosen in part because of the wide breadth of the different types of epidemics that we have here. We have Seattle and New York, who are quite far along in their epidemic control. We have Atlanta and Miami, who are non-ACA adopters, who are among who have the fastest growing HIV epidemics in the nation. We also have some really important demographic shifts that are happening in these cities. So I'll point your attention to the population changes. Atlanta has growing really rapidly, and the demographic is shifting towards more Hispanic and Latinx, towards the Hispanic Latinx population. In all of these cities, the share of the white population is coming down. At least that's what the projections are telling us. And we also have other fast-growing cities like Miami and Seattle included. So these are all factors that we incorporated, and they're actually quite meaningful in the bigger picture here. We used a compartmental model to do this. So naturally, HIV, certainly there's no question about it, is spread through networks of people exchanging sex, sharing needles. The question for us was a pragmatic one. First of all, we wanted to do something, to build a model that could simultaneously consider all of these different types of interventions at once. Second, we really wanted to replicate the entire epidemic at a city level. And so it was always a question of how well could we do that with a network-based individual level model. If you collect data from a prospective cohort study, it's a question of internal validity and external validity. How representative are the results of that cohort study for a given city? I think those are, to an extent, empirical questions, and we're really happy to be working with Will and his team to do some cross-validation work with the Titan model to help us answer some of those questions. But these are all practical choices. We wanted to make this as real world as possible and integrated as much evidence into this, real world evidence into this, as we could. The key linchpin here, however, and Will touched on, and I'm glad that he did, I'm glad that I'm just reiterating these points. It's not only that access to care is unequal between Black, Hispanic, and white populations, is that there is not a lot of mixing that goes on between them. So that's portrayed in the right panel here. The dark bars along the diagonal is mixing within their own group. So you see it's more prominent among heterosexuals, but you still see the darkest bars along the diagonal among MSM. And so these are two different, I like to think of these as two different manifestations of racism, really, that are complementing each other and creating these disparities and really driving them and driving them further. Patrick's excellent paper in the Lancet talking about the epidemiology of HIV in the US really highlighted that very clearly. So that's a dominating factor in all of this work, okay? These are the 16 interventions that we chose. They are not an exhaustive list of all possible interventions that we can do in HIV. These were picked out of the CDC's compendium. We felt they had the strongest evidence base, and these are the things that we could parameterize as best as we could. So it was about collecting data on effectiveness and cost, but also scale up. We had to make some estimates on how quickly we could scale and to what extent we could further scale up these interventions, because we didn't want to make sweeping assumptions about to what extent we could scale these interventions up. So we've really tried to integrate implementation scientific principles into this work. We've collected information on the cost of implementation, delivery, and maintenance for each of these. We assumed it would take us 18 months to scale up these interventions, and then we held them constant until 2030. One thing that we're lacking right now is really good implementation scientific evidence on the extent to which we can speed up, scale up, increase reach, increase adoption, and what we can do for sustainment. So I think those implementation interventions, those are coming. I'm really excited to see that development in the field. I think that's absolutely necessary. That is going to be the difference maker at this point. And we're going to have our eyes open for any sort of evidence that we can input into this modeling effort as we proceed. So when we look at these interventions one by one, You can see the list of the 16 in the y-axis there. The top group are the prevention initiatives, middle is testing, bottom are art engagement and re-engagement. So you can look at their independent effects on incidence reduction. And the big story is there's going to be no silver bullet that gets us to a 90% reduction. There's no one intervention that can get us there. That said, PrEP is going to play a big role in this. It will have to if we want to get to 90%. So with our pretty ambitious scale-up assumptions for PrEP, we found that it had the biggest single impact among all the interventions that we assessed, although you'll see the testing interventions are also really important. And the impact was biggest in the cities where scale-up hadn't happened to the same extent, right? So Miami, Baltimore, these are the cities that would benefit most from scaling up PrEP further. And by the way, we made the assumption, those scale up, the data that we used to determine our scale up parameters, we wanted some evidence in the real world, right? So we wanted something documented in the public domain. For PrEP, we're basically assuming that it could be scaled up again, the extent to it's been scaled up, to the extent of scale up in the first few years, okay? So it's an ambitious assumption, but there is still a lot of ground to cover with PrEP scale up. And so we felt it was within the realm of possibility, even if it was ambitious. So the goal of the project was not to look at these individually, it was to look at all the different combinations that would give us greatest value. So that's what I'm showing you here. These are health production functions. So on the y-axis, we have incremental health benefits measured in QALYs, and on the x-axis, you have cost. And so the figures, the lines, those are health production functions. They give you the highest valued implementation bundles for every investment level, okay? And so you can go along the health production function and you stop where it becomes, it's no longer cost effective to add another intervention, okay? So probably not surprising given the differences in these epidemics across cities. Each city's health maximizing combination implementation strategy was unique. They all had between 9 and 13 evidence-based interventions. The extent of benefits, the extent of incidence reduction varied greatly across cities. And of course, the cities that had the greatest need, Miami, Baltimore, Atlanta, they would benefit the most from this. They would have the largest percentage reductions and the greatest quality gains, okay? So nothing terribly controversial, but I'm going to highlight a couple of these cases as case studies to illustrate the impact of PrEP here. So on one hand, we have Seattle, which is a largely white and older population that saw a large scale up of PrEP in the early going. An additional scale up of PrEP we found, so these two clusters, every gray dot, that is one of 23,000 of the possible different combinations of these 16 interventions, okay? So we have two clusters here. On the left, it is without PrEP, and on the right, it is with PrEP. And so you can see they are basically parallel on the y-axis. So adding PrEP adds a lot of cost, but not a lot of benefit. Why? Because the scale was already there. And critically, we didn't make any assumptions on redistribution. We assumed that if scale-up was going to happen, it was going to happen in proportion to current levels of access. We knew this was, we didn't want to assume that the inequities would effectively evaporate, okay? But hold on, we'll get to that point later. So initially, Seattle, including PrEP, generated an additional 168 QALYs and reduced an additional 5.7% of infections by 2030, but at a high incremental cost and an ICER that is not good value for money. So typically we judge $100,000 per QALY is what we are willing to pay for an intervention, and 1.54 million is obviously a lot more. Contrast this with Miami. Okay, so again, 2 clusters on the left with PrEP, on the right without. So in a place like Miami, where there's a high level of unsuppressed virus, a lot of undiagnosed cases, you really need PrEP to get the kind of value that you need to drive incidence down. So if you look on the right-hand cluster, if you take the costliest strategy, so furthest to the right, that dot had limited testing interventions, no syringe exchange, and no PrEP. It was estimated to cost almost an additional $1 billion compared to the optimal strategy, and delivered only 30% of the QALY gain. And PrEP was the driving factor. As you see, these are 2 clusters. The left-hand cluster, PrEP, the right-hand cluster, no PrEP. So huge factor in a city like Miami with a large unsuppressed population, undiagnosed and unsuppressed population. Again, we always knew that scaling up according to proportional, according to access at baseline, we knew that wasn't going to cut it. We wanted to make the point that, you know, we really actively need to address these inequities by redistributing efforts. Okay, so we wrote up a follow-up paper, which is a distributional cost effectiveness analysis. And we considered a scenario where we didn't scale up in proportion, keeping racial and ethnic groups in proportion, but we scaled up in proportion to the number of new infections per racial and ethnic group. So this is, we've used PrEP in Baltimore as the illustration here. You can see that in the middle, you have our baseline level, and 78% of PrEP users were white, 5.3% were Hispanic, and 16% Black. In the proportional services scenario, we're keeping these percentages the same. If we actively try to reduce inequities, we see a much different distribution after the fact, okay? So that had a profound impact on our results. And of course, the cities with greatest need and greatest inequities benefited from this most. So Atlanta, Baltimore, Miami, and Los Angeles all benefited greatly from an equity-oriented approach, okay? So that is a huge story in all of this. EHE was right in focusing on specific jurisdictions with high HIV incidence, but the other key factor are these inequities in access to treatment and prevention services by racial and ethnic group. If we can address that, then we might have a chance at reaching the very ambitious goals of the EHE initiative. There are a number of questions here that we need to ask ourselves going forward. PrEP, the price of PrEP, really challenging to get at. I've had some really baffling conversations with colleagues who are frustrated at this by themselves, that they don't even know how much PrEP is costing them in their local formularies. We know the list price of Descovy. We have some idea of the price of generics, but you know, the question remains, how much are we paying for PrEP? Are we getting a fair deal, and how can we ensure this? Because it absolutely matters. What further structural changes need to occur to facilitate access to PrEP, particularly among Black and Hispanic populations? What are there effective implementation strategies we can use to increase uptake and persistence, particular in the populations that need it most, which again are urban, Black and Hispanic, Latinx populations? And then we need to consider innovative technologies and other modes of use, long-acting regimens, PrEP on demand, offer via partner care. To what extent can these make a dent, and how well can we scale them out? These are the questions that we're going to be focusing on in our work moving forward here. And, you know, the principle will always be trying to integrate real world data to populate these models and come up with reasonable projections on what we can expect to achieve. So that's what I've got. I'm going to thank my team, the Health Economic Research Unit, all the folks that put a lot of effort into this work, our gracious Scientific Advisory Committee, the HIVRN, the CDC, and our other partners who have shared data. I just want to thank all the staff and students who have put a lot of work towards this project, and our excellent Scientific Advisory Committee. You know, we wouldn't be, this project wouldn't be what it is without them. So we're really grateful for their support. And I'll stop there. Thank you.
Thank you so much, Bowden, and thank you, William. Those were two excellent presentations. And I have a few questions, but folks, please put questions in the chat. One question just to start off from Justin Smith is, Bowden, would there be location-specific slide decks that you might be able to make available? That Justin's very involved in the EHE initiative in Atlanta and would love to have Atlanta-specific slides.
Yeah, I presented in Atlanta at Emory in February of 2020. So it feels like a lifetime ago, but yes, we have Atlanta-specific slides. This is, you know, we don't have all of the most updated data and all this work. This is getting a little older. We're updating our evidence synthesis now. And so it's just a caveat that, you know, 2019, 20 data is starting to come in, and we'll be updating this as we go. But yes, I'd be happy to share those.
Great. Thank you. Before, Susan Lill has a great question, but I just want to ask one thing first. In both models, how do you account for some of the funky heterogeneity about the issues we're dealing with? So two very specific examples. HIV transmission, it's not always dyads, you know, so that they're clusters of people who may be sharing needles. Pre-COVID, there were bathhouses and places where, so you kind of have not kind of a linear kind of progression necessarily as the virus spreads in different populations. And then the other issue is what kind of assumptions do you make about differential non-adherence and transmission, both adherence to PrEP and adherence to ART, since some of the people who may be engaging the greatest risk may be less likely to be adherent, and that may throw the models off a bit as well.
Will, do you want to go first?
I can start. At least I think it's one of the great strengths of agent-based models in that you can incorporate a significant amount of heterogeneity. So at least in our model, there's population level distributions for numbers of partners, numbers of sex acts within dyads, propensity for using condoms, all of those sorts of things are incorporated so that not every agent looks exactly the same. You have some agents that only have a handful of long-term mutually monogamous partnerships. You have some that have lots of short turnover, some with some concurrency. You know, you get sort of as much of a simplification as possible of quite a lot of heterogeneity there. So at least HIV transmission is not happening the same exact way for every single agent. And we try to capture that as much as possible. We also try to parameterize all of our agent behaviors with local data as much as possible, and stratify where possible for subgroups so that we recognize, you know, some groups struggle with adherence more than others for any number of reasons. And so that's reflected that on average, one group may have a lower adherence to PrEP than others. The correlation between the two, between poor adherence and maybe more risk behavior, is interesting. Our model doesn't correlate those yet. It would be interesting to explore sort of the strength of that correlation and how much it matters. It's possible, but we definitely try to incorporate as much of that heterogeneity and as much of that subgroup specific information as possible, so that at least everything is believable on its face. I always love presenting these sorts of models to people who work on the ground, and they're like, this important thing is missing, and then we go and figure out how to put it in a model.
Yeah, I mean, a lot of the answer is similar. Of course, ours is more coarse, right? We're only looking at high and low risk people in different risk groups and different ethnicities. So it's aggregated up rather than trying to specify different characteristics of individuals in a city. I think it's like, it's at least a philosophical question, maybe an empirical question, the extent to which the projections, the thing is, we're looking at projections into the future. And so judging which one is accurate and which one is not, like I think we lose some specificity, but I like to think that we are close. And I like to think that we can test these things, right? So at least by looking in the past, we can do some cross-validation between models. But again, the whole orientation for us was PrEP is one strategy among many that we need to consider. And, you look at ART retention rate, ART uptake and retention, that is another story that needs to be told here, right? When we looked at HIV-RN data, it was the Black population in the South that had much lower retention on ART. And that's a big story in all of this, which I don't see that often, right? That we need that individual level data to tell us these things and to determine the extent to which persistence on ART plays a role in all of this. And it is a significant.
Yeah, no, it's going to be a challenge. I don't know if it's time varying covariates, but certainly it's not a one and done, any of these interventions. So it's going to be a challenge as you think through the complexities of modeling people, cohorts aging out, aging in, et cetera. Susan Little asked about, did you look at the relative cost of PrEP scalp when adjusting for racial ethnic equity? And then do you look at reasons why the benefit of PrEP is so variable by city? Your early slides of benefit seemed much lower in LA compared, for example, to New York.
LA is an interesting case. It had us scratching our heads for a long time. I think LA stands out because of the incredibly high prevalence of HIV, existing prevalence of HIV among Black MSM there. It was much higher than in other cities. And so the benefits of PrEP in a mostly closed, segregated sexual network is much lower than otherwise. And so ART retention interventions were more important, relatively so, in Los Angeles and other cities. Otherwise, it was really about the extent of scale up that had already happened, baseline levels, okay? And ensuring you get the right racial ethnic distribution at baseline is really, really critical. If you gloss over that fact and you assume it's sort of equal between racial and ethnic groups, you're gonna get a completely different answer, okay? So Seattle, New York had done an excellent job up until 2017, 2019 in scaling up PrEP. Some of the other cities lagged far behind. And so that's why you see Miami getting such a massive benefit from PrEP, right? PrEP is really like, the benefits of PrEP are, if you think of a theoretical world where there was no unsuppressed virus, PrEP doesn't have any benefits, right? Its benefit is relative to the size of the unsuppressed population, right? And I think the other question was about costs. So we didn't have information on how much more it costs for an implementation strategy specifically aiming to reduce inequities. What we did was we assumed the same cost and said, okay, this is the added benefit that we get. This is how much we expect to save because the added infections averted. This is how much more we can spend to reduce these inequities. And there was a lot of slack there, right? There is a lot of value in developing implementation strategies specifically to reduce these inequities. That was the key point that we made in our paper. We don't have this information. We don't have real world data. Implementation science is in its infancy. We still need a lot of evidence in that domain, but the point is there's a lot of value in doing these things.
Thanks. William, any additional comments you'd like to make? No?
Not at the moment.
Okay. Patrick, you want to ask your question, maybe our last question?
Sure. I just think you both sort of gotten at this a bit, but I think just to have a short segment of saying, like, who are the policymakers who need to hear this, and how do you boil down these messages? Is it health department folks? Is it local or federal government? Is it payers? Just, it's a challenge. Like in 5 minutes, please solve our issue of communication with policymakers. But like, what are the on the other hand, I think that sometimes this kind of evidence can shape a conversation in the way that just surveillance data or observational cohort data, to William's point, don't. So who needs to hear this, and what are the most effective ways, or what have you already done to start these conversations?
Say Bohdan go first.
Yeah. It's complicated, right? You have a lot of different payers representing different interventions and different segments of the population. So certainly Ryan White is a big player in this, and Medicaid is a big player. But if we really want to increase access among the populations that need it most, we need to engage health departments in this. I don't really see any other way. I don't see the payers involved in providing the drugs. That is almost separate to the effort that needs to happen to reach these people, right? So we have tried to engage on multiple levels. It's been very challenging in the COVID era. Everybody's tied up with COVID. But we're trying to engage on multiple levels, because it is really multiple payers and multiple actors at the city, state, and federal level that have to get involved to coordinate this. Even though the action has to happen at the local level, that the CDC needs to be involved given their role as payer. Ryan White needs to be involved. SAMHSA needs to be involved. It's if we believe that it is an all hands on deck, multiple combination implementation strategies is going to happen, we need a lot of different people at the table.
I will note that the name check for CDC, and we will make sure that we also share. I mean, I know that they're aware, but also just sharing the link and trying to promote that discussion. William, your thoughts, but also just a question of whether, like, your particular focus on health equity. I mean, it sounds like there's a couple different ways to go at this from a motivational point of view, and so what have you? Who do you think needs to hear this, or who have you shared this with, and how do we put the health equity argument up alongside the sort of economic arguments?
Yeah, I think it's interesting. Before I met Bohdan, I used to be very averse to health economics. I was like, they don't care about equity. They want to maximize who saves money, and like, it doesn't matter. And now it's been great to work with you to be able to see, like, there is an economic case for equity, and
absolutely,
it is not only cost effective, it's cost saving in many circumstances. So financially, it's not an option to maintain the status quo. I think what I take away from many of these modeling exercises, particularly the critique is always like, well, this is armchair, it's a model, it's not on the ground, it's removed from reality, is that at least it shows us what our possibilities are for our futures, right? Like, our models are projections, we can change them, and we can make different choices. So at least I think this is a way to very clearly make the case to the stakeholders that are responsible for action and the policymakers that are responsible for allocating the money, for like what their options on the table are, in making those futures a little bit more imaginable. I think it's hard to say, like, invest $1 million in this thing and it'll get us this, if you can't show someone what the alternative is. So I like to use modeling to at least show people what's possible. One of the first places I presented an iteration of this work was the National Minority AIDS Council's Biomedical HIV Prevention Summit. And that's mostly practitioners, case managers, all the kinds of people that are responsible for the day-to-day of getting people on PrEP. And that messaging was just to tell them that, like, what they're doing is important, worth investing in, and that they're working towards the kind of ideal future that a model could show us is worthwhile. I don't know.
Yeah.
I think that's what draws me to modeling, is it shows you what's possible, and you're not always limited by what's observed. You can make your assumptions. Maybe that's the Maybe that's the leftist in me that like just wants to say, well, of course that's possible if we just tried hard enough. So I think it's
That's
a
great.
good way to show our health department folks in particular what's possible with the tremendous work that they do.
That's great. And so we'll have that be the last word for today, but I do want to encourage people to mark April 4th on your calendar, same time, same place, for Dr. Shaheen Lockman from Harvard, who'll be speaking on PMTCT. So quite a different topic, but I want to thank our speakers again on behalf of Ken and the CFARs and myself. Thank all of you for coming, and wish you a good rest of your Monday. Ken?
Thank you, everyone. Great talks. Thank you both.
Thank you.
Thanks.
Take
Thank
care.
you.